Thank you, Dr. Paul, for inviting me for the Tuesday lecture, and thanks for this nice introduction. Apologies in the beginning that I have a little bit of laryngitis, so hopefully my voice will not cut or interrupt in the middle. Assalamu alaikum. Thanks all for coming and attending. As highlighted by Dr. Paul, my talk today will be about the safety updates on the use of NSAIDs in sport medicine. As most of you are aware that NSAID is one of the most commonly prescribed medications to treat pain and inflammation for athletes. And again, as most of you are aware, these agents are associated with some side effects. They can cause gastrointestinal side effects, cardiovascular side effects. Also, they carry or have a negative impact on the kidney and liver as well. Unfortunately, the cardiovascular safety profile for these agents recently have come into question, especially after the results of the approved trial, which resulted in the voluntary recall of the medication rofecoxib or Vioxx from the market in the year 2004. However, not all NSAIDs carry the same degree of risk, which is something that I'm going to be talking about today in my presentation. So there's nothing for me to disclose. So what are the learning objectives for today? We are going to discuss the latest updates in regards to the cardiovascular safety profile for these agents. We are going to discuss the guidelines that will help the healthcare professional to strike a balance between a GI side effect and a cardiovascular side effect when choosing an NSAID for an athlete. Also, we're going to discuss the misuse and abuse of these agents by the athletes and what are the recommendations to stop this phenomena. And also we're going to talk about how to manage some NSAID-related side effects when we are talking about the negative impact of NSAIDs on the kidney and on the liver. And before I begin, let's have a look together at some important facts, starting with an article from Choll and Schneider, who stated that up to 30 to 50% of elite and non-elite athletes are actually frequent users of NSAID. And another interesting fact is 70 million prescriptions for NSAID have been prescribed and dispensed in the United States. Not only this, around 11% of athletes in the Summer Olympic Games in Athens, they were using NSAIDs. 1/4 of the Sydney Olympic athletes were using NSAIDs. And according to Mark Stewart in the Olympics of London 2012, more than 300 prescriptions of NSAID has been prescribed and dispensed to the athlete. And according to the FIFA Medical Assessment and Research Center, they stated that up to 40% of the medications dispensed were actually NSAIDs. And that was between the year of 2002 and the year 2014. And for the Women's World Cup, between the year 2003 and the year 2007, again, up to 40% of medication dispensed were NSAIDs. And this is again from London 2012, from an article by Mark Stewart, who stated that most of the prescriptions that has been prescribed to the athlete were NSAIDs, including ibuprofen 400, 200. We have the diclofenac 50 and diclofenac 75. If we put them all together, it will be more than 300 prescriptions of NSAID that has been prescribed and dispensed in London 2012. And to continue in facts, as most of you are aware, NSAIDs are classified or divided into two groups. We have the traditional NSAID or the conventional NSAIDs, and these are non-selective NSAIDs, meaning they work on inhibiting the COX-1 and the COX-2 enzyme. And we have the selective ones, and these are what we know them by the name of COXIB or the COX-2 inhibitors. They basically or selectively they inhibit the COX-2 enzyme at the site of inflammation. And as I mentioned before, a very important fact to remember that not all NSAID carry the same degree of risk. Some have a higher propensity to cause a GI side effect, and some have a higher propensity to cause a cardiovascular side effect. And before we continue, let's have a look together on how NSAIDs works. What is the exact mechanism of action? Most of you are aware of the mechanism of action. I know you're familiar with this slide, so I'm going to do a quick review for it. After a tissue injury or a trauma, usually arachidonic acid will be released from the phospholipids by the effect of phospholipase enzyme. And then it will go through the cyclooxygenase pathway. It will go through the COX-2 enzyme, and this will be responsible in giving us the bad prostaglandins, which mediate pain and inflammation. And when it goes through the COX-1 enzymes, it will give us the good prostaglandins, such as the ones that maintain the integrity of gastric mucosa by increasing the mucus production and less acid secretion. But how NSAIDs works, NSAID works by inhibiting the production or blocking the production of NSAID, of prostaglandins through the cyclooxygenase pathway. So if we receive the traditional NSAID, it will block the COX-2 and the COX-1 enzyme. If it blocks the COX-2, it will give us the desirable effect in relieving the pain and inflammation because it will stop the production of the bad prostaglandins. But also it will block the COX-1 enzyme. Unfortunately, it will stop giving us the beneficiary prostaglandin, and there will be compromising the gastric mucosa, hence causing more GI side effects such as GI perforation or bleeding. And if we received only the COX-IBs or the selective COX-2, they will only block this channel without affecting the COX-1 or minimally affecting the COX-1 channel. So let's start our talk about the relationship between NSAIDs and athletes. It's not a secret that athletes are frequent users of NSAIDs. As I mentioned before, 1/4 of the Olympic athletes were using NSAIDs. And more than 10% of athletes were actually using more than one NSAID at the same time. And I think the relation, there's a good relation between athlete and NSAID, I think, because these medications are over-the-counter drugs. They don't need a prescription. The athlete can have an easy access by getting it off the shelf. And another reason is these agents are not on the WADA list. They are not prohibited. I think that's another reason for this easy access. Unfortunately, some of the athletes are using this medication prophylactically. Some are using it for indicated pain and inflammation, but some are using it prophylactically to block the pain before even it occurs. And some are using it for a long period of time, chronically, without realizing or with limited awareness in regards to the side effects of these agents. These agents are not benign. That's what we need to always tell the athlete. These agents are not benign. They are associated with side effects, as I mentioned before, on the heart, kidney, liver, and musculoskeletal system as well. So how the prophylactic use of NSAID can negatively impact the musculoskeletal system. As I mentioned before, if you are using it prophylactically to block the pain before it occurs, it will allow the pathology to progress. Another reason is the COX-IBs and the prostaglandins plays very important role in the production of the extracellular matrix, which is the collagen that makes our musculoskeletal tissue strong. But if the NSAID is going to be blocking this work of the COX-IBs and the prostaglandin, we are going to cause less production of the collagen, which makes our musculoskeletal tissue weaker. Also, exercise by itself, it's an inflammatory process in the body. The higher the physical exercise, the more the tissue adaptation to this exercise. But if we take an NSAID and we block this inflammatory process, we are reducing the tissue adaptation to this loss produced by the physical exercise. And according to the data that found in the literature, that 1 out of 5 athletes experience side effects when they are using NSAIDs prophylactically. And to share with you some data from our own practice, a survey was conducted in a Shamal Sport Club by our colleague Dr. Suhail Shibi. He's the clinic director of the Shamal Clinic. He conducted a survey to study the prevalence of NSAID consumption by the athletes, and also to study the awareness of the athletes in regards to the use of NSAIDs. It was done on the first team, so around 23 or 24 athletes. The period was for 6 months from March to September 2017. Age was minimum of 18, maximum of 35 years old, and most of them have an experience more than 13 years. This is the survey that has been done. It's almost 13 questions. It was done by Dr. Suhail, reviewed by myself, Dr. Karim Shamari, and Dr. Yassine from OPD. And it's basically questions in regard to the knowledge of athlete to wear the NSAID, and their knowledge about side effects, if it's prohibited or no, how many they are taking, from where they are getting it, why they are using it, and the frequency for using it. So there is almost 13 questions. And the survey actually answered that 96 of them, they are actually using painkillers. The frequency majorly was on a weekly and monthly basis. 52% were using it before competition. The reason for consumption, that 78% they are using it to participate in competition. Unfortunately, 74% of them, they are not aware of the side effects associated with the use of NSAIDs. 61% they didn't know if these medications are on the prohibited WADA list or no. And also 70% they were obtaining their NSAIDs for an indicated use, of course, from the clinic director, from Dr. Suhail, but also the 70% they were also getting it from different resources, in addition to the other 30% where they were getting it from different places. And the most commonly used anti-inflammatory, or the one that they are resourcing, or the one from Dr. Suhail, is diclofenac and the celecoxib. They were ranking the top 2 of the list. So what was the conclusion from this study? It's actually the conclusion coincide with the results or with the data we have worldwide, that athletes have a limited awareness in regards to the side effects associated with the use of NSAID, and that athletes are potential candidates to be misusing or abusing these kind of medications. So what is our role? Is to ensure appropriate education, to inform them to use these agents only for short term, not for long term, to be used not prophylactically, but for clinical indication, and to be prescribed by a physician or recommended by a pharmacist, and again to increase the awareness to avoid using more than one NSAID at the same time, because this can increase the risk of developing a side effect. And the most important thing, of course, we have to remind them to take this medication with food, because it can increase the risk of causing GI complications. One question that always has been asked in any sport-related topic, where it's about the use of NSAID in fracture or muscle injury, and will it actually delay healing? So I know this is a common question. So far, no, there are limited data for human study to say if it will delay the healing or no, but there are some animal and observational human study that suggested that there might be a delay of bone healing or muscle injury, muscle tissue healing. But other studies actually show there is no effect. And let's keep in mind that if we go back to the mechanism of action of NSAIDs, we said it blocks the production of prostaglandins. One of the prostaglandins is PGE2, which plays a very important role for the bone formation and bone production. So maybe if you are using NSAID for bone fracture, maybe it will delay the healing if we look at the mechanism of action. And again, inflammation is very important for the healing process. It's important for the regeneration and the repair, because whenever there's a trauma, there's a blood flow to the area. This will bring more oxygen, more nutrients, and getting rid of the toxic debris and the dead cells. So if we look at the pathophysiology and the mechanism of action of NSAID, it has been agreed among sport medicine from the literature to avoid using NSAID for long term. It's maybe best to be given at a minimum dose for a short period of time of 3 to 4 days to help with the inflammation and help the athlete to go back into his normal life. But again, the decision, if it's going to delay the healing or no, this remains controversial. Let's talk about the second adverse event, which is the cardiovascular side effect. Recently, concerns in regard to the cardiovascular side effect has been more noted. Not only in regards to the COX-2 or the COX-2 inhibitors, it has been extended to other traditional NSAIDs. But why these agents were linked to cause cardiovascular side effects? The best answer was found based on the mechanism of action. So let's have a look again at how it works out. In a healthy normal vascular system, usually there is a balance between two arms, between the prostacyclin and the thromboxane. Thromboxane is a hormone prostacyclin type. It's produced by the platelets, and it's mainly modulated by the COX-1 enzyme. Thromboxane is known to cause vasoconstriction and a powerful or potent stimulator for platelet aggregation. Prostacyclin, PGI2 mainly, it's predominantly controlled by the COX-2 enzyme, and it's found in the COX-2 channel, and it's known to cause vasodilation and also inhibitor for the platelet aggregation. As I said before, in a healthy normal vascular system, there is a balance between both arms. But whenever there is a tissue damage or an injury and we receive a treatment like COX-2 inhibitor or an NSAID with selectivity toward COX-2, it will block the COX-2 channel, meaning it will block the effect of the prostacyclin, disrupting the balance between both arms, making the effect of thromboxane more dominant, which will result in causing more platelet aggregation and more vasoconstriction, hence causing further cardiovascular events such as MI and stroke. This theory is known as the Fitzgerald theory. It's so far the best theory or explanation that is given to why these agents are associated or linked or correlated to cause cardiovascular side effect. When did it all start? It started in the year 2004. Most of you remember most probably this incident after the results of the approved trial, which showed that rofecoxib has been linked to increase in major coronary event by 5-fold. Mainly it was MI. And then MSD voluntarily recalled the medication Vioxx or rofecoxib from the market, which pushed the FDA in the year 2005 to issue a warning and request all manufacturers of NSAIDs to update their labels to include a black box warning to state that all NSAIDs are associated with increase in cardiovascular side effects, the risk to develop a cardiovascular side effects, and increase in the risk to develop a gastrointestinal side effects. In another word, there is no NSAID that's free from both. After the withdrawal and the recall, after the withdrawal and the warning from FDA, a lot of questions have been raised in regards to use of this agent in high and low cardiovascular risk patients. Accordingly, too many studies were conducted to answer some of these questions. Starting with the Danish study in the year 2010, which was done on 1 million healthy individuals. The results were that all NSAIDs are associated with increased risk, regardless if it was coxibs or a traditional NSAIDs. Then in the year 2011, then we have the meta-analysis MACE. It was basically to study the effect of NSAID on the major adverse cardiovascular event. And it was the patient were mixed between healthy individual and patient with established coronary heart disease. Rofecoxib has the highest risk to develop a major adverse cardiovascular event. Naproxen has the lowest MACE, followed by celecoxib. And diclofenac, surprisingly and interestingly, had a similar risk to develop a cardiovascular event, the same as rofecoxib, the medication that was withdrawn from the market. Then another study came out, which is the CNT study, which was one of the most credible studies and the one that provided the most robust data in regard to the cardiovascular safety profile for NSAIDs. It included a 780 randomized clinical trial comparing as NSAID versus NSAID and NSAIDs versus placebo. And it was done on patients who were chronically using NSAID at high doses. The patients were low risk at baseline, and they were using NSAID for a short period of time of less than 1 year. Naproxen was not associated with increased risk. These were the results. Ibuprofen, diclofenac, and all COX-2 inhibitors were associated with increased risk. And as I said before, these were used at high doses. What was interesting in this result, that the ibuprofen increased at high doses at 2400 milligrams, increased the major coronary event by 2.2 folds. And all the COX-2 inhibitors, celecoxib, etoricoxib, lumericoxib, they were all associated with increase in all-cause mortality, which both of them, I think, were very significant data provided from this study. CNT, by the way, stands for the coxib traditional NSAID trial list. I forgot to mention that. With all these studies, there were 3 questions that were not answered. What about the long-term risk in using NSAID? How fast the risk to be developed? And what about the risk in patients with established coronary heart disease? In a systematic review in 2011, 9 out of 12 studies actually showed that new users of NSAIDs showed elevated cardiovascular risk in the first month. Again, very interesting. Observational studies in 2011, this were studied to the risk to develop a cardiovascular event in patients with established coronary heart disease, mainly incident of death and recurrent MI. The risk was high with rofecoxib, celecoxib, and diclofenac. Naproxen, the risk was high only in the first 7 days or after using it for more than 90 days. But the general conclusion, what was the most important thing about the study, that there is no safe duration of NSAID use after an episode of MI. Finally, in the Danish study in the year 2012, again, they were studying the risk to develop a cardiovascular event in patients with established coronary heart disease for a period of 5 years. So basically, they were studying the risk for developing cardiovascular death. The risk of death was actually apparent over the 5 years period with all NSAID except for the naproxen. So what we learned from all these studies, what were the major conclusions from all these studies? That diclofenac at high dose, it carry the same risk to develop a cardiovascular event like rofecoxib, Vioxx. Ibuprofen and diclofenac at high dose, they carry a high risk to develop a cardiovascular event. Naproxen carry a low risk to cause a cardiovascular event. And finally, it appears to be no safe NSAID or no safe duration for the use of NSAID in patients with established coronary heart disease. This was further confirmed by the European Medicine Agency in the year 2013. In the year 2014, another interesting thing took place in Canada. Health Canada issued a warning in regards to the dose of diclofenac, requesting all diclofenac manufacturers to update their dosing information and to change the dosing, to state that the maximum dose is 150 milligram, not anymore. It should be 100 milligram. That's the maximum dose. This basically to minimize the risk to develop a cardiovascular side effect. So yes, now in Canada, the dose of diclofenac, the maximum dose is 100 milligram, not 150 milligrams. And if you go to the Qatar National Formulary here you can find it in the app on your phone, you will see that the Canadian labeling for the diclofenac maximum dose is 100 milligram a day, not 150, to minimize the risk of developing a cardiovascular side effect or event. Again, in the year 2015, FDA issued another warning, requesting all manufacturers of NSAIDs to update their label again to reflect the following important 4 points. The risk can occur as early as the first week of using an NSAID. First week. And I think that's most probably related to the mechanism of action due to platelet aggregation. The risk is greater at high doses and long-term use. And this has been confirmed by all international heart associations, including the American Heart Association. Risk occurs with or without risk factors. The risk is there, but it will be higher in the presence of risk factors. Finally, not all NSAIDs carry similar risk of increased cardiovascular event, and this was clear in the studies mainly with the naproxen or with low-dose ibuprofen. In the year 2016, there was a very important study that the results of a study known as the Precision Trial or the Precision Study. I'm not sure if anyone was aware of it. It was a huge and big study. It was initiated in 2013. It was sponsored by Pfizer. And it was one of a few head-to-head trials between 3 different arms, between celecoxib, ibuprofen, and naproxen. And the purpose of the study was to compare the cardiovascular safety profile of celecoxib to naproxen and ibuprofen. It was done on a 30,000 arthritis patient, mixed between high and low cardiovascular risk patient. The dose of celecoxib that was used was low to moderate, 100 to 200 milligrams. The risk of naproxen was high, 1,000 milligram, and the dose of ibuprofen was up to 1,800 milligram, which is fairly high as well. The results were published in the year 2016, and the results were really astonishing. At moderate doses, celecoxib was found to be non-inferior to ibuprofen or naproxen with regard to cardiovascular safety. It means that the risk to develop a cardiovascular event with celecoxib is the same as ibuprofen and naproxen. So it was non-inferior. This study received a lot of criticism because the discontinuation rate was high. The dose of celecoxib was low, as I said, 100 to 200 compared to high doses of ibuprofen and naproxen. And the patients where they were used were actually low risk at baseline. But still, with these results, a lot of physicians, scientists, and researchers start to look differently at the COX-2 family. Because in the past, COX-2 inhibitors were always linked to cardiovascular event. But with this study, with celecoxib, it showed the non-inferiority or the same risk to develop a cardiovascular event like ibuprofen and naproxen. In the year 2017, last year, a study was published in the European Heart Journal. It's actually, I will just go through this briefly. It showed that the risk to develop a cardiovascular event, such as cardiac arrest, the risk was 50% and 30% respectively with the use of diclofenac and ibuprofen. And the general conclusion from the study that, again, ibuprofen should not be used more than 1,200 milligrams. The safest NSAID is naproxen. And the riskiest NSAID, especially with patients with established coronary heart disease, is diclofenac. In this slide, I'm just highlighting the cardiovascular safety profile for other coxibs that are or were in the market. Etirocoxib, which is available in the state of Qatar, but as most of you are aware, etirocoxib is not FDA approved. It's not available in the United States. And it showed that the risk for developing cardiovascular event is the same as or comparable to other traditional NSAID. And its risk to develop a cardiovascular event is the same as diclofenac. Valdecoxib was withdrawn long time ago due to Stevens-Johnson syndrome, and also it demonstrated some cardiovascular risk following an open heart surgery. Lumiricoxib also was withdrawn in the year 2007 because it demonstrated, again, a cardiovascular risk that's greater than other NSAIDs. The third side effect associated with the use of NSAIDs is the GI side effects. It's not a secret that NSAIDs are associated with increasing GI complications. Of course, the risk, it varies depending on the presence of risk factors. And to highlight the degree of the risk, according to the Rheumatology Medical Journal, in 1 month time, the risk for GI bleeding or perforation and the risk for peptic ulcer is increased 4-fold and 5-fold respectively between users of NSAID versus non-users. And again, to highlight the risk, in the United States, according to the American Journal of Gastrointestinal, 25% of chronic users of NSAID will develop ulcer disease, and 2 to 4% will bleed or perforate. And these GI events will translate into 100,000 hospital admission and 7,000 to 10,000 deaths each year in the United States. And in some references, actually, I found the death is actually can go up to 16,000 deaths each year in the United States. These are the risk factors that if they are present, they will increase the risk for GI complications. I'm not going to mention any of them. Well, I'm going to mention a few that actually match the criteria of our athletes, male gender. We have the use of NSAID at high doses, multiple NSAID usage. As I said before, more than 10%, they use more than one NSAID at the same time. Long-acting NSAIDs, and this is common with some medications like piroxicam, who has a long half-life, more than 57 hours. And again, sustained release formulation rather than immediate release formulation. What we know from the clinical trials, ibuprofen and the COX-2 inhibitor seems to possess the lowest risk. The risk is there, it's just only low, but the risk cannot be eliminated or excluded. Ketorolac, piroxicam, and maybe naproxen possess the highest risk to cause a GI event. What can be done to improve the GI safety is to provide gastroprotection by providing gastroprotective agents. And of course, we will consider these gastroprotective agents, again, depending on the presence of risk factors, such as misoprostol, which is a synthetic prostaglandin, proton pump inhibitor, and H2 receptor antagonist, COX-2 inhibitor that can be given alone or with a PPI, and finally, H. pylori treatment if needed by giving the triple or the quadruple therapy. So now we talked about the cardiovascular side effects and the GI side effects. Sometimes it has been challenging for some healthcare professional on how to strike the balance between the GI side effects and the cardiovascular side effects when we want to choose an NSAID to our patient. This challenging question was answered by the American College of Gastroenterology and the Canadian Society of Gastroenterology, who provided guidelines. This guideline has been divided into two parts. We have a low and high cardiovascular risk, and we have a low and moderate and high GI risk. And the best way to explain it is by giving an example. If you have a patient who has a low GI risk and a high cardiovascular risk, the safest thing to give is naproxen or low-dose celecoxib. If we have a high GI risk patient and a low cardiovascular risk patient, The safest is to avoid NSAID, not to give NSAID. Or maybe, if we need to give NSAID, to give celecoxib plus a gastroprotective agent. I want to grab your attention to the high cardiovascular risk. In the past, in the year 2009, the drug of choice for the high cardiovascular risk was only naproxen. But after the precision trial that I explained to you earlier, where we showed that celecoxib, it carried the same risk like naproxen, they added low-dose celecoxib as a second option in the high cardiovascular risk patient. So what has been concluded in the precision trial actually has been reflected in this guideline. The fourth side effect associated with the use of NSAID, which is the hepatotoxicity. According to the World Journal of Gastroenterology, about 10% of all cases drug-induced hepatotoxicity are associated with the use of NSAIDs. Knowing that the use of NSAID is only associated with mild elevation of the aminotransaminases, not major. These are the liver enzymes. And so far, the chance to develop a hepatotoxicity with NSAID is not common. And the incidence to develop a hepatotoxicity with NSAID is 100 times less than the incident or the risk to cause a cardiovascular side effects or a GI side effects. Oral diclofenac, Solindac, and piroxicam still carry the highest risk. Ibuprofen, so far, it sounds to be the safest because it has a short half-life and it has no toxic metabolites. The fifth risk, which is the negative impact of NSAID on kidney. In the United States, 1 to 5% of the patient, they actually experience adverse event because of the use of the NSAID on the kidney. It translated to 2.5 million who experience a nephrotoxic event annually in the United States. As I mentioned before in the beginning, due to the mechanism of action, NSAID block the production of the prostaglandins. Some of the prostaglandins are good for us. So if we take an NSAID and it will block the production of the vasodilating prostaglandins, this will restrict the blood flow to the glomerulus of the kidney, which will result in ischemia. That's why the American Society of Nephrology issue a strict recommendation for the use of NSAIDs in patients with risk factors such as hypertension, diabetes, or heart failure, or with patients who are chronically using high doses of NSAIDs. So what are the recommendations by the American Society of Nephrology is to consider in this group of patients other treatment other than NSAIDs, such as acetaminophen or paracetamol, tramadol, or short-term use of opioid. If you want to use an NSAID, try not to use NSAID with long half-life, more than 12 hours. Stick to the one with short half-life, mainly low dose of ibuprofen, low dose of naproxen, and low dose of aspirin. And to highlight the nephrotoxic effect of NSAIDs in high endurance sports such as marathoners or sports that require strenuous exercise, please note that 75% of marathoners or runners who run long distance, they use ibuprofen for pain and inflammation. But according to Harvard University researchers, in a study they conducted, they found that the risk to develop an acute kidney injury, the risk is doubled for these patients. And that's not only because of the prostaglandins that we mentioned before, also because there's a higher rate of dehydration in this high endurance sport. When there is a higher rate of dehydration, 40 to 50% of the blood flow is less or is restricted to the glomerulus of the kidney. So we are actually doubling the stress on the kidney, causing ischemia. And again, in this study, it showed that 18% higher rate of acute kidney failure, acute kidney injury was observed in marathoners who used ibuprofen versus non-users. Before I move to the end of my presentation, this is the last thing I want to highlight. I'm not sure if any of you is dealing with athletes who are taking a low-dose aspirin for heart protection or non-athlete taking low-dose aspirin. It's very important to remind the patient to avoid taking these NSAID at the same time with the aspirin or low-dose aspirin or the baby aspirin. These agents should be taken 1 to 2 hours after the aspirin or 8 hours before the aspirin for two reasons. The first, because it increases the risk to develop GI side effects. And again, because ibuprofen, aspirin, it works as an antiplatelet agent. That's why they call it the baby aspirin for heart protection. Because it works exclusively in the COX-1 channel. It blocks the work of the thromboxane, which I mentioned earlier, that cause vasoconstriction and platelet aggregation. But if you give naproxen and ibuprofen at the same time with aspirin, they will compete at the site of action on the platelets, and they will cause only irreversible inhibition for the platelets and the thromboxane. Whereas aspirin, it causes an irreversible inhibition for the platelets. That's why it's the only NSAID that causes the only NSAID that can be used as an antiplatelet agent for heart protection. Again, this is a poster that was done by Dr. Suhail Al-Shamal. Again, this showed the commitment of NSMP to increase the level of awareness among athletes in regards to NSAID and the side effects associated with it, in addition to doping. Because these medications, some of them, as I mentioned before, they have pseudoephedrine that can be tested positive if they are used in the wrong way. I wanted to leave the auditorium today bearing in mind the following key messages. All NSAIDs, they are associated with some side effects. There is no study to say which NSAID is better than another NSAID, but definitely there are studies to say some NSAID are riskier than other NSAIDs. Naproxen so far is found to have a neutral cardiovascular side effects. Still, the risk cannot be excluded or eliminated, but so far is the safest. For cardiovascular risk patient, the safest NSAID is no NSAID. But if you have to give an NSAID, go with the ones that I mentioned in the studies, which is naproxen and low-dose celecoxib. According to the American Heart Association, prescribing NSAID should be done at the lowest effective dose for the shortest period of time. And finally, for a patient to have a high risk to develop a GI complication, we need to consider agents such as the gastroprotective agents such as PPI or H2 receptor antagonist to protect or to minimize the risk to develop a cardiovascular gastrointestinal side effect. These are the references used for my presentation. I'll be happy to share it with you after the presentation. Thank you so much.